Welcome to this evening's webinar, Pediatric ENT in Focus, Hearing Loss and Cochlear Implants, Tonsils and Adenoids, what GP needs to know. My name is Serena, your ICGP representative for this evening. We are joined by our presenters, Dr. Michael Barricade and Clinical Professor Catherine Bierman, and GP Facilitator Dr. Vani Anjunamani. Before we get started, I would like to make acknowledgement of country. We recognize the traditional custodian of the land and sea on which we live and work, and we pay our respects to elders, past, present, and emerging. I myself am joined from Gadigal land located in Sydney CBD. I'll also like to acknowledge any Aboriginal and Torres Strait Islander colleagues that have joined us online this evening. I would like to introduce you to our presenters. Dr. Barricade is an ear, nose, and throat surgeon with expertise in pediatric and adult ENT surgery. He provides specialist care for both children and adults with ear, nose, and throat conditions. Dr. Barricade is a member of the Australian Society of Otolaryngology Head and Neck Surgery. He has an ongoing commitment to education and research in otolaryngology head and neck surgery. Clinical Professor Bierman is an ENT surgeon specializing in adult and pediatric cochlear implants, otology, and pediatric ENT. She is a clinical professor at Macquarie University and Sydney University, staff specialist Children's Hospital at Westmead, and the medical director of Nexus, member of the ASOHNS, and has published and presented extensively, participating in trials and grant on cochlear implants and hearing devices. Dr. Anjunamani is a full-time clinician for over a decade. She enjoys evidence-based chronic disease management and preventative healthcare in high-risk populations. As our ICGP supervisor, she imparts a systematic approach to multi-morbidity to her registrars. Welcome to our presenters. I'll now pass it on to Vani, who will go over to the learning objectives.
Thank you, Serena. So today we're going to look at recognize the clinical indications and referral criteria for tonsillectomy and appendectomy in pediatric patients. Secondly, we're going to provide evidence-based guidelines for pre-operative preparation and post-operative care to support children and their families. Thirdly, we're going to look at apply current criteria for pediatric cochlear implant candidacy, including early identification and referral pathways. And lastly, we'll evaluate recent cochlear implant technologies and patient outcome.
Thank you so much for the invitation to speak. And I think, GPs are pivotal in patient care, and that actually includes hearing health and the various treatments for that. So it's a wonderful opportunity to give you an update today. So we're going to talk a bit about cochlear implant journey, referral pathways for cochlear implants, various hearing tests for children at different ages, some investigations, and I'll give you some examples of cases. And then a few other things such as binaural hearing in both ears, and also various more cochlear implant advances. So a patient can be referred for a cochlear implant, and that often comes from GPs, from other ENT surgeons, from paediatricians, and from audiologists. And in Australia, like in most places in the world, cochlear implant clinics are associated with the major paediatric hospitals in your state. They can sometimes be associated with universities more overseas, but in Australia, it's generally with your main hospitals. A cochlear implant evaluation is really a multidisciplinary team assessing the child. So there's an ENT surgeon who's specialised in cochlear implants, speech pathologist, audiologist. Often there's a social worker involved, and there may well be teachers of the deaf and also biomedical engineer. It's really important to set realistic expectations, and for those with congenital profound hearing loss, about a third of those children will have additional needs. So we really need to look at clear understanding for the family about expectations. The surgery involves an ENT surgeon who's specialised in cochlear implants, and we do some intraoperative testing to actually check that the implant's working, and it gives the audiologist a head start in setting up the map which is where they change the electrical parameters so that you can hear more and more. So at the end of the case, we can come out and say to the family, we know the implant's working and everything's gone well. And then the post-operative course is actually more involved in kids, I guess, than adults, because a lot of those little ones have not actually heard before. The map is adjusted so that it's slowly made louder and louder up to a normal loudness level, because otherwise the children would just reject a too loud sort of sound if you just turned it straight up to a normal volume. And then they have what's called habilitation, which is really a form of rehabilitation where the child's taught how to listen and then has speech and language training as well. And we do lots of cochlear implant supported testing to check that everything's working well. And then, of course, they need long-term follow-up. So we check that the cochlear implant's working. They have access to replacement equipment, upgrades, clinical follow-up and troubleshooting. And there's a huge input from families because they're doing most of the therapy, auditory training for the kids at home. Hearing Australia plays a big role, and we'll talk more about that. Department of Education, their local speech therapists, and there's cochlear implant user and family support groups as well. Now, looking at the background, so from neonatal hearing screening, which picks up 98% of children born in Australia will have neonatal hearing screening. And if a child has a hearing test, they're actually being compared with a loudness sound, a template at 35 decibels. So they'll either be a pass or refer. They get 2 screening opportunities. If they're referred, then they're referred to their local paediatric hospital audiology department, who will do diagnostic audiology testing. So that's where the audiologist will be taking this auditory brainstem response down to threshold, trying to see what the child can hear at different frequencies as well as how softly they can hear. And if the child has a hearing loss with air conduction, like a sensorineural hearing loss, but even a conductive hearing loss, they'll be referred to Hearing Australia. And they'll also be referred for a medical assessment, which involves a paediatric ENT who's specialised in ears, a paediatrician, and there'll be some genetic testing as well. At Hearing Australia, they provide free hearing aids and hearing tests and support for children up till the age of 26, so 25 years, they'll get free hearing aids and all this support. So a case history, we've got a little kiddie who was referred on neonatal hearing screening. They were diagnosed with profound hearing loss at birth. So you can see here this pediatric auditory brainstem response, and the child's hearing is more than 90 decibel loss at, say, 500, 2 kilohertz. On the left ear, there's 90 decibel loss, but otherwise more than 90 decibel loss. So this child has profound hearing loss. They've been referred to Hearing Australia, ENT, paediatrician, and an early intervention program. The child's also been diagnosed with congenital CMV, and that's the cause of this child's hearing loss. The child's received hearing aids through Hearing Australia. We've organised an MRI scan under sleep, and that shows normal inner ear anatomy. And the Hearing Australia then adjusts the hearing aids by doing a test called an aided cortical evoked response. So you wear your hearing aids, they put sound in at different loudness levels. So you can see here it's at 65 decibels or at 75 decibels. And different sounds, an g, t, s, are actually heard like an audiogram in the low to higher frequency range. And so what we can see for this child is at 65 decibels, which is often at conversation language. They're not hearing with their hearing aids, with the 2 hearing aids on. We can't see any objective brainwave responses. But at 75 decibels, so, a bit more of a shout level, then the child is able to hear. So we can see that hearing aids are not enough, but certainly there's some transmission of that auditory signal along the auditory nerve. They then undergo candidacy evaluation for a cochlear implant. So we check whether these various ling sounds, so these sounds again in low frequencies and high frequencies, whether the child's even noticing a sound's being said, let alone can they actually imitate what that sound is. There's a parent questionnaire, which is looking at the auditory performance of the child. And we can see that all our test results, both objective and subjective, are all aligning, and the child's not hearing enough with their hearing aids. So we can go ahead with a cochlear implant, and this child had bilateral cochlear implants at 7 months of age. Now, as a child gets older, we can do various subjective hearing tests. So there's behavioural observation tests where you're looking for the child to startle, or maybe they start sucking their dummy a little bit more in response to a sound. It's not super accurate, but somewhat. We then do the visual response observational audiometry. So the kiddie has a puppet, and they're sort of trained that when they hear a sound, they turn towards the puppet. But that can only test their best hearing ear. They'll have play audiometry where we can test both ears, and they're sort of playing a game in response to the sound. And then as they get older, they can do a proper pure tone audiometry. Now, hearing loss may be progressive. So those kids who might be born with mild hearing loss will continue to be followed up with regular hearing tests through Hearing Australia, because we know that in certain groups of kids or certain reasons that they have their hearing loss, they might have up to a 50% chance of having progressive hearing loss. So connexin 26, the most common cause of congenital sensorineural hearing loss, it's responsible for 50% of non-syndromal congenital hearing loss. 1 in 33 of us carry the gene. About a quarter to 50% of those kids can have progressive loss. There's a condition called large vestibular aqueduct syndrome, where on the MRI scan we'll see an abnormally wide connection between the fluid around the brain and the inner ear, and they'll often have stepwise hearing loss. So again, through Hearing Australia, we can do regular hearing tests on these kids. We can also do various questionnaires, and we can give them support both with hearing aids, an FM system with the school, and they have regular follow-up with an ENT as well. So for an older child, the child might have hearing loss, and this may well be a child that's been wearing hearing aids, and we just do a test and we can see that the child's had some hearing loss, or maybe the child's noticed they're not hearing as well. It might be a sibling of a child who's deaf, so you're a bit more screening those kids, or family member who's deaf. You might have a child who's just seeming to be a bit speech delayed, and you're wanting to check that that's not due to hearing loss. Or maybe mum's just suspicious, or dad's suspicious of hearing loss, and so we want to do a hearing test. And, the big thing is parents know best. If there's any doubt, we can arrange a hearing test, either subjective or objective, depending on their age. So the subjective tests we've gone through, and the objective tests are more these diagnostic ABRs. And sometimes we have to do that under a general anaesthetic, particularly with kids with additional needs, where you're not sure if their speech delay is due to their developmental delay or because they're not hearing well. The child will then have a diagnostic hearing test, and they'll be referred to Hearing Australia for hearing aid fitting. For some kids, they may well be directly referred to a cochlear implant program for candidacy evaluation. And also Hearing Australia are constantly checking that those kids are hearing enough with their hearing aids, and if in doubt, they'll send them for candidacy evaluation as well. So the indication for cochlear implants are basically when hearing aids are not enough. It doesn't give you access to the whole of the speech range. So this is another case history just to show you. So a child who passed hearing screening. This child had had lots of recurrent ear infections and glue ear, and had multiple sets of grommets with his ENT surgeon. He'd had hearing tests after those grommets, but by about age 7, those hearing tests were becoming a bit more unreliable. There was comment that he was having difficulty concentrating. The hearing results seemed to be fluctuating, particularly in the last 6 months. The child had been referred to Hearing Australia and had received some hearing aids, wasn't really wearing them much, and so they were referred to the Children's Hospital at Westmead, where our audiologist did auditory brainstem responses, because nobody could get a firm handle on what this child was actually hearing or not. The child had been recently diagnosed with developmental delay, ADHD, and also speech and language delay. And the kitty had noticed some tinnitus. Now, you only get tinnitus with progressive loss. Congenitally deaf children don't get tinnitus, which is interesting. The deafness paediatricians had referred the child for some genetic testing, and that had all come back normal. But what you can see on the audiogram is that this kitty, who was born with normal hearing and had passed hearing screening, now was more in the severe to profound hearing loss range. So we saw the child, MRI was arranged, and that showed some abnormal inner ear anatomy. So maybe this was the cause of this progressive loss. The genetics, as I said, hadn't shown any issue. The child had had the hearing aids then adjusted to this new sort of severe to profound range, and the kitty was delighted that he was hearing so much more, but the hearing was continuing to fluctuate a little bit. And so the child was referred for candidacy evaluation. And certainly if your hearing's getting into that severe range, often hearing aids are not enough. So we look at those ling sounds and we can see that he's able to detect them, but he's obviously not hearing them as clearly because he's having some difficulty with imitation. Then we looked at the aided speech perception, and you can see that left ear, which was the worst hearing ear, is only getting 40% correct on common phrases and 10% correct on word scores. So word scores, you don't have any context, and that's often a harder test to do. That peach test, which we saw on the other child, the parents were really reporting that the child wasn't really hearing much at all. The vocabulary test is showing that the child was now very speech delayed, language delayed. The articulation and phonology was again delayed to some degree, and speech and language assessment showed different areas of either low or marginal or on words he was average for his age. So there was certainly some good evidence that this child wasn't hearing enough with the hearing aid, and in fact was now quite markedly speech delayed, often in a very low percentile group. So the child underwent a left side cochlear implant at age 8 years old and is delighted now with more hearing and more reliable access to sound. There's many causes of hearing loss, and we're familiar that genetic now makes up about 50%. There's all those perinatal issues such as antenatal infections, such as CMV, perinatal, such as needing to go to ICU and prematurity, and then of course postnatal, such as infections, meningitis. And there's still about 25% that we don't know the cause. There's about 1 in 1,000 children born with severe to profound hearing loss, a similar number with a lesser degree of hearing loss, and that same number will actually develop severe to profound hearing loss with progressive hearing loss over the first 2 decades of life. These two scans, you can see an MRI scan here, and you can see this widened corridor. So this little spot here is your cochlea, your vestibule, semicircular canal. It's an axial MRI, and you can see this wide corridor, which is this enlarged vestibular aqueduct, which on the CT scan with bone, you can see this wider corridor. And so CSF rushes up into the cochlea. Cochlear implant candidacy has changed over time. And really, it's when you hear better with cochlear implant. So, 30 years ago, you had to be profoundly deaf. Now, we know that children with and adults with more residual hearing in the low frequencies, where 20 decibels is normal, but dropping down into that severe or profound range, they'll probably do better with a cochlear implant. But a hearing test is just almost like a screening test. It's just a first step, and it's so useful to do, but that might then trigger a candidacy evaluation and a more in-depth testing, as you could see with those other kids. This is the Hear Lab, which was that aided cortical test we mentioned with the child who was picked up as a neonate. And these different speech sounds actually represent different frequencies along the speech range. And so we can pick up whether the child has hearing loss. Either they can have the testing unaided, so without the hearing aids, or with the hearing aids on, and picking up what gets to the conscious brain level. So it's been fantastic in being able to adjust hearing aids really rapidly in those first few months of life where a baby's responses might not be as reliable. And also it's then meant that we can step in with a cochlear implant in a very timely manner because we're sure that the child's not hearing enough through their hearing aids. So pediatric assessment, we do various hearing tests as we've discussed, and we look at the functional tests, and these are really dependent on their age. The Ling sound, so that idea with the audiogram that you've got some low frequency sounds such as the oo and the ah coming across into the middle, and then the s and the sh more in the higher frequencies. Whether they can detect that and whether they can imitate, whether they can actually get a clear understanding of the two sounds. We do categories of auditory performance, the various speech perception of words or sentences, speech and language assessment, and then questionnaires as discussed before, depending on their age. The MRI scan is vital in a pediatric cochlear implant workup because we want to check what the anatomy is of the cochlea. We also want to check that they have a cochlear nerve. So this is a transection of the internal canal along the canal, like cutting up a salami, and you could see it's got the smiley face, the 4 nerves, and the cochlear nerve is anterior inferior. So we really want to check that. And you can see on the picture on the right-hand side in the lower screen, this child has a facial, the vestibular nerves, but there's no cochlear nerve. And then up here, you can see a child with a large vestibular aqueduct, and then this is called IP3 or X-linked recessive, a very abnormal connection between the internal canal and the cochlea, and that is filled with CSF. So we can pick up a lot from the scan. About 20 to 30% of kids born with hearing loss will have some abnormality on their scan. We generally go for an MRI rather than a CT because of the radiation, and then we only use CT in very abnormal anatomy. So referral pathways for pediatric cochlear implantation evaluation, certainly Hearing Australia, from the GP, from the paediatrician, from the diagnostic audiology department at their local paediatric hospital, and then of course pediatric ENTs. And as we discussed, there's a multidisciplinary assessment, and we liaise closely with Hearing Australia, their GP, paediatricians, Department of Education, and then early intervention providers, speech therapy, and NDIS. So when do we provide a cochlear implant? Well, it's the deafer you are, the quicker we can come up with that decision that you'll do better with a cochlear implant than you will with hearing aids. So if you're bilaterally profoundly deaf, you'll be able to have a cochlear implant before the age of 12 months. If you're more moderate to severe, maybe profound, we'll often fit a cochlear implant for the worst hearing ear, and then the better hearing ear will have a hearing aid. But sometimes it takes a little bit longer for the child to give you that necessary sort of testing results to be sure that they're going to do better with a cochlear implant than a hearing aid. If the child has progressive hearing loss, then we can step in as the hearing drops, and it's good to really monitor these kids. And hearing aids give a richer, more natural sound and are better for music, but cochlear implants give a clearer sound and can give you sound right across the speech range, so they're very good for speech. And then, of course, if there's sudden sensory or hearing loss, particularly if there was meningitis as a cause, that might be an urgent need for a cochlear implant, because bone can actually form inside the cochlea, and you might only have a couple of weeks or a month or two to be able to get in a cochlear implant before the bone forms. And sudden sensory or hearing loss needs to be investigated. And often these kids might have a cochlear implant because they were born with 2 hearing ears, and families are more keen for that. Teresa Ching at the National Acoustics Laboratory, which is linked with Hearing Australia, had this opportunity when they were rolling out neonatal hearing screening in different states, that we had an uptake in neonatal hearing screening in different states. So Hearing Australia, which is a federal organisation, had the situation where some kids were being diagnosed within a couple of weeks of life with their profound hearing loss, and other kids were being diagnosed at age 2 or 3 because their state hadn't started neonatal hearing screening. So this was a progressive prospective study, and they looked at the children's then a complex thing, global language score, which she made up of out of sort of 10 different testing at age 5. And what you can see is that the kids who received a cochlear implant, say at 6 months, which there are not many there, but from their sort of line of best fit, were pretty much in the middle of that global language score, middle of the 1 standard deviation. By 12 months, the average child who received a cochlear implant was still in that 1 standard deviation, around the mean for this global language score compared with normal kids, normal hearing kids, I should say. And then at 24 months, this average is now within the 2 standard deviation, but you can see it's now dropped out of that 1 standard deviation. So certainly if it's straightforward, we'd like to provide a cochlear implant in that first 12 months of life. But if they've got more hearing with a hearing aid, they're actually being stimulated by that hearing aid. So we're not wasting time. Those brain pathways are being laid down. So if we look at the outcomes, 1/3 of children with cochlear implants do have additional needs, and that might influence their speech and language outcomes. So careful counselling is really important. Children may have complex abnormal anatomy, and that can affect their outcome. And in this study, we reported about 1/4 of the kids had abnormal anatomy. Children with no developmental delay or autism are expected to have excellent language outcomes, and often by 12 months of age, they're starting to have good speech understanding, and we would expect for these kids to go to their regular local school. And for children with additional needs that might affect their ability to gain verbal language, hearing in their environment certainly improves their quality of life. They're often hearing music, they can hear people speaking, and so they can turn towards them. They can hear people approaching, so they're not frightened by somebody just turning up. So there's good quality of life benefits for those kids as well. Binaural hearing is best, so that's hearing through 2 ears, and that can be either through a cochlear implant in 1 ear and a hearing aid in the other, or 2 cochlear implants if that's where your hearing is, or even you can have normal hearing in 1 ear and the opportunity of a cochlear implant in the other ear. You hear better in quiet, so that's called summation. You hear better in noise, that's called the squelch effect. You get directional hearing if you get input from both sides, and you get rid of that head shadow if you get input from both sides. If we look at recent advances, most of these big advances over the last 40 years with cochlear implants have been the cleverness of the speech processor, being able to analyze sound, change it to a digital signal, and provide what the brain really needs. And also this connectivity, so the speech processors will connect directly to your phone or your iPad. You can stream directly, which has been great. There's novel devices with steroid-eluting arrays to try and decrease any inner ear reaction to a cochlear implant, maybe improve residual hearing preservation with surgery, and there's a lot happening in that area. And there's a lot of work trying to improve hearing in background noise, which is always the problem, and music appreciation. Concurrently, there's gene therapy, where we're looking at, we did a study at RPA where people who have hearing loss, often the nerve endings, the neurites sort of wither with the hearing loss, and we're able to regrow those towards the cochlear implant with gene therapy. And at the Children's Hospital at Westmead, we're doing a study at the moment, pumping DNA into a cochlea for a specific type of genetic hearing loss to try and bring hearing back. And this is, a very exciting area that will keep improving. Now, I really wanted to share with you, now more apps are providing fairly accurate hearing screening. And I had a teenage boy whose hearing is fluctuating with large vestibular aqueduct syndrome. And I said to him, well, why don't you just use this Mimi app, which is a free app. It's very fairly reliable. Professor Daniel Lin in America has really suggested we all know our hearing score. And so you can do a hearing test through good quality earpods and see what your hearing is like in 4 frequencies and get a score, which is your 4 frequency average. And then you can do that every day if you like. And if it's suddenly dropping, then you go and see an ENT urgently, or you go into emergency if it was suddenly dropping, or you see your audiologist for a proper hearing test. So I really encourage people to use that. And for this teenager, that was a really good option for him. The other thing is that as kids get older, if they have mild hearing loss, they often don't want to wear hearing aids. But Hearing Australia do provide them for free, and we encourage that. But there are hearables where you can, even your Apple AirPods Pro 2 can actually be set up to be for mild to moderate hearing loss and amplify sound. And again, that teenager that I mentioned really thought that was a good idea, that he was happy to wear that rather than his hearing aid. So do have a look at that. So in conclusion, I'll just play you this.
This on your uniform.
And my hat color is green too, because I don't really like a color uniform. I really want to only wear my own clothes because it's better than uniform, better than uniform.
Ooh.
So this little girl was born with congenital profound hearing loss. She had cochlear implants around that 12-month of age, and now she's 5 years old and talking about going to school. So these kids really don't have a robotic voice. They hear they speak beautifully, and yeah, you know, really the indications for cochlear implants are when hearing aids are not enough. Thank you.
Thank you, Catherine. Thank you for both presenters for answering all the questions, but I thought I'll go through some of the more pertinent ones for the whole audience. So there was a comment on sleep apnea. So I guess one of the questions we have for adults, validated screening questionnaires. Is there any validated screening questionnaires in the pediatric populations? Michael? Catherine?
Yep. No, unfortunately not. So, oh, Michael, would you like to answer?
Oh, sorry, my thing was just muted. What was the question, Kathy? Screening
Questionnaires in
for
pediatrics for obstructive sleep apnea.
Oh, well, usually what happens, the parents will be referred by a GP, and usually the patient's seen the GP several times for snoring or sleep disturbance, thrashing about, waking up through the night, all the usual sort of symptoms. And then they'll come and see me. They'll often play a video which documents sleep disturbance. If I'm not sure, I'll refer for a pediatric consult with usually Dominic Fitzgerald, and Dominic will usually do a sleep study. In terms of screening questions, just all the usual things: snoring, witnessed apneas, restless legs, waking up through the night, the usual sort of things.
Sure.
But
we don't, Kathy?
Yeah, but we don't promise that we'll stop them waking up through the night. So
No.
one of the big things I always ask is, how do they sleep? And if they sleep with their head extended, that's often a sign of a child with obstruction. You know, kids more do these hypopneas where they take a half deep breath, but not a complete stopping breathing. But with parents being able to video or audio their kids, it has been fantastic, because it's really been out, you know, we'll often watch this and go, no, your child has obstructive sleep apnea. Often that waking up in the morning tired, daytime, you know, still needing a nap in the afternoon, though they're, you know, a bit older. They're all sort of symptoms that will often, and that choking in their sleep, or, you know, crescendo, give us an idea. But no, unfortunately, there's no easy questionnaire for kids.
Right. So there was another question about pre-workup for adenoidectomies. So you know, some parents want evidence of sleep apnea before they would go to a surgeon. So where can we refer, public or private, and what are the costs there?
Look, I think that's well, I'll let Michael. Sorry.
Oh no, I'm happy if you to answer, Kathy, please. Yeah, because it is hard to get a free sleep study straight away. It's almost impossible.
It's impossible. But I totally agree that, you know, for parents, if the child's borderline, I normally refer for a sleep study, or if the parents want it, and that's, you know, that's fair enough. The major public hospitals do have sleep units, but they often have quite a wait time. But, you know, we refer in, and they will have some triage sort of system.
Sure.
But you know, and this is where ENT, if the kid obviously has obstructive sleep apnea, we will take out their tonsils, and it will be much quicker. You've cured them, rather than waiting for a sleep study. If they're a clear case, then tonsillectomy, adenoidectomy will cure their problem. And even for kids with additional needs, you know, kids with low tone, we'll often get a sleep study just to check that they, you know, aren't CO2 retaining, or because they might need to go to ICU post-op, or if they have central apneas. But even those kids will be improved by having their tonsils and adenoids out, even though they might not be completely cured.
Sure. So just another point, the last point on the adenoids for both of you, the allergies component, does that need to be tested at all? Because there's a lot of allergies that can contribute to it, and adenoids can grow back. So some of the questions our parents ask.
Yeah, it's a good question. I think it's easy to test for. I'd usually just do a RAST, or if there's any difficulty, I'd refer for an allergist consultation. I think the allergy issue more relates to turbinate hypertrophy. Quite often we'll need to do turbinate reduction together with adenoidectomy in order to provide a good nasal airway. And the other benefit, if we do diagnose a coexisting allergy, we can treat that. So it's quite easy to treat that with Claritine, intranasal steroid spray, and also environmental modification. Avoid dust and smoke, try and have a low allergy bedroom, wash the sheets and towels with hot water. All those sort of things can help those patients with allergy. And then there's immunotherapy. So we have lots of children now. My children had it. They have treatment with immunotherapy, and that can help the allergy. But I would say it's not a substitute for adenoidectomy. It's more of an adjunctive treatment.
And I'd only add...
Is that your experience, Kathy?
Yeah, well, look, I'd just only add that the allergy symptoms are quite... so nasal obstruction may well be because of allergic rhinitis, or it could be because of the adenoids. But the allergic rhinitis will have symptoms. I mean, they have often an itchy nose, sneezing. They might have a history of asthma, or there might be atopy in the family. They're often sort of rubbing their nose. So, you know, you often just from the history get that idea. But if you just tilt the nose up and look in the front of the nose with a torch, you'll see if they're allergic, they'll have these big, swollen, purple, boggy inferior turbinates. And you can just see that in a child by just tipping the tip up. And so if there's an allergic component, you can certainly treat with a topical nasal steroid. That will help shrink down the inferior turbinates and decrease the mucus production and all that. It will actually also help shrink down the adenoids. Adenoids, you know, maximum at age 3 or 4, 3 or 4, and then they shrink and they're normally gone by age 12. So the topical steroids can help shrink those down as well along the way.
Great. Now, Catherine, question to you. You mentioned the lovely referral pathways we have, and there was also a question about Hearing Australia providing free services, and it's for eligible Medicare patients. So what about overseas visitors or refugee patients who we find have delayed hearing, or they have hearing aid and they have issues with hearing? What happens to them?
I think, you know, the refugee group I think Hearing Australia have some degree of ability to support them.
Mm-hmm.
So, you know, it's still worth referring to Hearing Australia. The hospitals, the children's hospitals will often do a hearing test. You know, we have refugee clinics. And so the children's hospital will often do a hearing test to, you know, and not be charging a refugee family. So, you know, again, refer through your main hospitals, pediatric hospitals, and then, you know, we can see what services we can get. But we certainly have had situations where we haven't been able to offer a cochlear implant for a refugee family because they haven't got the right status yet. But once they have residency, they can certainly access Medicare.
Sure. And just to get because we all got, I think ConsultMed is the software to refer for GPs in the clinics. What particular clinic are we referring to if we find a child is a candidate for cochlear implant? Is it the hearing? Is there what?
Yeah. So your ENT outpatients will have at the pediatric hospitals have a whole lot of different clinics. You know, airway clinics, hearing clinics. So, you know, if you just ask for the, you know, otology or the hearing, you know, ENT clinic, then they'll get, you know, you'll see somebody and you know, they'll get them in. Again, you can refer first to you know, audiology department if you're unsure what's going on, and that's another method, and then they'll often refer them directly to ENT, and we often see them within a week or two. So but Hearing Australia now will also see kids. They used to only see kids who were diagnosed with hearing loss, but they will now see kids who are not diagnosed. Now, they might charge them for that first test, but once they've been diagnosed with hearing loss, then they're in that system as well. So, there's over 120 Hearing Australia branches all over Australia. So, that's a possibility as well.
Sure. And now this is a very good, interesting question. So with cochlear implant in very young children, does it need a revision as they're growing up because the anatomy is changing?
Great question, and I should have pointed that out. But so the cochlea is the only organ in the human body that's adult size at birth. So that's why we can do cochlear implants in little babies. And as they grow, the bone will form up around the skull. Often the implant, sitting on top of the surface will become sort of a bit more cradled in the bone, but the cochlea doesn't change, and that can stay there. So no, we don't necessarily have to change anything. It's pretty amazing.
Yes, it is. Now, the other question was it's saying for bilateral aqueduct syndrome in young kids, how strict do we need to be regarding simple falls without witnessed head injury, regarding hearing tested or starting prednisolone?
Yeah, look, I think, it's how long is a piece of string. I've seen kids fall off just a couch, and we've started them on steroids, and even and mum and dad have got a just in case script, and they've lost their hearing. So I think often I say it's a knock that they would cry for, say, 5 minutes for, but if in doubt, just Hearing Australia will fit them in, or our local audiology will fit them in, diagnose pediatric audiology for an urgent hearing test, because we do want to get on top of it. And it's better to give the child, we give the prednisone at 1 milligram per kilo. And if they had 1 or 2 doses, 1 or 2 days prior to getting into the hearing test and they didn't need it, 1 or 2 doses of prednisone in a child is not going to be, a major problem compared with, weighing up, getting in early with the steroids.
And so that's great. I think if I have one more question, Catherine, what is the oldest patient you have done cochlear implant for?
95 is the oldest that I've done.
Wow.
Yeah, so in fact, what's interesting is we think of cochlear implants for pediatrics, but in fact, our 70+ age group are now the largest group of cochlear implant recipients, because they're so helpful as you get that presbyocusis as we get older.
Okay, great. Thank you, Catherine. Thank you, Michael. I'll pass it back on to Serena.
Great. I'd like to extend my thanks to Michael, Kathy, and Vani for presenting, and to everyone who joined us online. A friendly reminder that tonight's session. We do hope you enjoy the session and that you also enjoy the rest of your evening. Thank you and good night, everyone.